So this is part one of the breast series. It's going to be a multi-part series. Starting out with an introduction here, just going to go over some basic vocabulary, basic localization and stuff. This lecture is mainly for people who are foreign medical graduates who have not done a lot of mammo or haven't done it here in the States. So a standard mammographic series that's performed here has two views: a cranial caudal view where the breast is compressed, and then the x-ray beam is shot from a cranial caudal direction. All of the imaging of the breast is done under compression. It supposedly lowers the dose and also makes for a better image. The second view that's performed is a medial lateral oblique view, and you can see that this view contains a portion of the pectoralis muscle. You also get a look in the axilla with this view. The first thing you want to do when you look at one of these things is QA it. Is it up to snuff? The way that you do that is by looking for, is there enough breast tissue that is on the film? People will tell you to draw this line from the nipple posterior to the pectoralis muscle, and they call that the posterior nipple line. Now that measurement there, you carry over onto your CC view, and it should be within a centimeter of the original measurement. And if it's not, then there's not enough breast tissue on the film, and you have to call it back for a technical repeat. If you happen to see a finding, people will use a clock face, a descriptor for where the lesion is located. So if we were looking, let's pretend the patient is laying down in front of us and we're looking at their chest, right and left breasts, just like a clock, 12 o'clock, 3 o'clock, 6 o'clock, 9 o'clock. And notice that it's sort of going to be different from each side. In other words, lateral on the right is 9, whereas lateral on the left is 3. So you have to sort of visualize these clocks in your head. You can't just memorize the numbers. 12 and 6 is always going to be the same, but 9 and 3 is going to flip. Now the upper outer quadrant is where most breast cancers are. So let's do a basic localization where we see a mass that's in two views. This is going to be the lateral part of the breast out here on the CC view, and this is going to be the medial part here. Superior, inferior, just to orient you if you're not familiar with these things. So in the right breast, laterally, and in the right breast, inferiorly, we have a lesion. So if we think back to our clock face, that is going to be inferior, below the equator, and lateral. So we're involving this right here. So it's going to be around 7 o'clock-ish. Would be 7 or 8 o'clock would be a fair enough wager. And if you were going to go in and ultrasound the patient, which you would, if this was a diagnostic callback, if you were seeing this, and we'll talk about this more, if this was a screener that just came through on the pile, in the United States, there's a age recommendation where women start getting mammograms every single year, all the way up until they're dead, basically. If you make a finding, it'll be called back into the diagnostic pile. Then if you confirm the finding is real, they'll end up almost always getting an ultrasound with a few exceptions. Knowing this clock face helps you when you go in the room or the tech goes in the room to scan the patient, where you have some idea where you don't have to scan the whole breast looking, and if you would happen to find something, you want to make sure that thing that you found was the thing that you saw on the mammogram as well. So people will do this stuff where they will sort of look at the distance between the nipple to the finding, and they'll sort of gauge how far out also this thing should be. Because once you get in there and you start ultrasounding, you're going to find a whole bunch of stuff. Cysts and whatever that may or may not be the actual thing that you were looking at. So there's two more advanced localization techniques that you need to know for multiple choice test, and if you would ever happen to be unfortunate enough to have to do this stuff for a living. The first one is, what if you see it only on the MLO, but you don't see it on the CC? So this is, the top image is showing you like a real time, this is the patient actually going to get the mammogram. And the bottom image is what's actually going to show up on the film for you to see. So you're only seeing this part. This is the part the tech is seeing, and we only know the lesion is here for the purpose of illustrating this technique. So is that the medial lateral oblique is obliqued. And as the x-rays pass through, they're projected on the film like that, and you get a picture like this. What you can do when you only see it on the MLO is you would order or recommend a true lateral, an ML. And this time, when the film is shot, you end up having this situation here, which creates an either a rise or a drop on the ML relative to the MLO. And this is what helps you localize it. A lesion that drops is going to end up being lateral in the breast. A lesion that rises is going to end up being medial in the breast. This is relative to the MLO. So in other words, if you've got this situation where you had your MLO, you made your finding, you ordered the ML, they did the ML, and the lesion appeared to sink, lead sinks, so L for lead, L for lateral, you'll end up finding that the mass will be located in the lateral breast. So this is helpful sometimes if you stare at that part of the breast on the CC, you can end up making it out, or when you go into ultrasound, you at least know that you're looking in the lateral half of the breast. So that can help you try to at least get a good guess on where you're going to be looking. And the opposite is true. If you made your finding in the MLO view, you had the tech perform an ML, you noted that the lesion rose, that means that when you end up looking on the CC or on the patient, you're going to end up finding that the lesion will be medial. So M for muffins, muffins are said to rise, M for muffins, M for medial, and that's the way that people remember it here. Lead sinks, muffins rise. So what if you only see it in the CC view? You can't see it in the ML, you only see it in the CC view. Then you can use a technique called a rolled CC. And the general idea is that, so here on the top is your conventional, this is the conventional CC, this is the one that you saw, and you've got a mass here, but you don't know if this is superior or inferior. So if you roll the breast and the lesion is in the superior breast, and you roll the breast medially, the lesion is going to be more medial on the rolled view. And then if you roll the breast laterally, it's going to move lateral. And that's true of lesions that are in the superior breast. So a lesion in the superior breast is going to move in the same direction that you roll. The opposite is true in the inferior breast, where if you roll the breast medially, the lesion is actually going to move laterally. And if you roll the breast medially, the lesion will move laterally. Or roll it laterally, it'll move medially. It's the opposite. An inferior breast mass will move in the opposite direction that you roll it. A superior breast mass will move in the same direction. So superior for same, SS. More vocabulary here. People will talk about scanning the radian. So that's basically like the triangular, if you were going to draw triangles on the breast along the clock face, that's what people are talking about when they say radians. There's another thing that's confusing, which is this idea of multifocal lesions versus multicentric lesions. Multifocal lesions are defined as the presence of two or more lesions, tumor foci, within a single quadrant of the breast, or within 5 centimeters of each other, so they're close to each other. Multicentric breast cancer is defined as the presence of two or more tumor foci within different quadrants. So centric, different quadrants, focal, they're in the same focal area. So greater than 5 centimeters apart. The word asymmetry is used a lot in mammography. There's a whole bunch of different kinds of asymmetry. Basically, you have a plane asymmetry is a finding that's only seen in one view. So remember we were going through those problem-solving scenarios where you only see a lesion in the CC view, or you only see the lesion in the MLO view. That would be, you describe that as an asymmetry. Now these other three are findings that are made in both views. A global asymmetry just means you've got more breast tissue relative on one side relative to the other. It's globally asymmetric. And you have to end up calling these back at least one time at the beginning to get a baseline and take another look. A focal asymmetry is a lesion that is seen on two views, but you haven't interrogated it completely to describe it as with using the right vocabulary words, because you haven't got a spot compression or a magnification views and those kinds of things. So that is basically, on screeners, people just call stuff focal asymmetries if they see them in two views and they're going to bring them back, and then they'll get fancy with all the vocabulary words on the diagnostic. And lastly, there's this thing called a developing asymmetry, which is bad, which means that there's a new thing that wasn't there before. Now, every couple of years, academic breast imagers in the United States get together and change the vocabulary words that they want to use slightly, and then they call that BIRADS. They usually have to have multiple meetings, lots and lots and lots of hours, and once they run out of academic days or their academic center won't pay for them to travel anymore, then they decide they've had a consensus and they put one of these books out. The general idea is that they can't have people going around calling stuff breast nodules, that they have a standard vocabulary where a certain description of a finding is going to be true in one half of the country as it is in the other half of the country if you're using the words correctly. So these vocabulary words exist for plain film mammography, they exist for ultrasound, and they exist for MR. I'm just going to go through the plain film ones and the ultrasound ones real fast. There is a group of vocabulary words that they will want you to use for calcifications, and I'm going to talk about that in the second lecture. So for plain film mammogram, they talk about three things: shape, margin, and density. Shapes are either going to be oval, round, or irregular. Oval, sort of like that, or that. Round, what you would expect it to be, round. And irregular, sort of like that. Margins can be either circumscribed, obscured, microlobulated, indistinct, or spiculated. Circumscribed. Obscured is when you're only going to see a portion of the border. So you can see there's a mass that has a border here that I can see well, but I can't see the rest of it. I sort of lose it. That would be an obscured border. Microlobulated is what it sounds like. Indistinct is sort of a fuzzy edge. You couldn't for sure, well, you may be able to trace around it, but you wouldn't be able to trace around it with a sharp pencil. You'd be more like tracing around it with a felt pen or something. And then spiculated is what you'd expect it to be also. The densities are described as either low, equal, or high, and then there's a distinct group of entities that are fat containing, and when you call something fat containing, you are essentially calling it benign. And this is all relative to the background parenchyma of the breast. So breast has either got parenchymal tissue or it's got fat tissue, and it's variable depending on the person. Some breasts are very fatty, some breasts are very dense. And that's another thing that BIRADS will ask you to comment on that I'm not going to talk about, but just know that it is in their vocabulary that they will want reported, and the makeup of the breast tissue is variable. Some people believe that denser breasts have a greater risk for breast cancer. They're certainly harder to read. So a mass that is low in density has a lower density relative to the background breast tissue. Equal is the same, and high would be if it looked more dense relative to the regular breast tissue. Now there's several fat-containing lesions, all of which are benign. The classic differential is a lymph node, hamartoma, galactocele, which is only going to be seen in a lactating patient, an oil cyst or fat necrosis, and a lipoma. So this is a hamartoma here, and this would be some fat necrosis. Ultrasound has a whole bunch of different descriptors. They are what you would expect, and similar to ultrasound descriptors in other parts of the body, like calling things anechoic, hyperechoic, hypoechoic, etc., commenting on the shadowing. Posterior features, is there shadowing, is there increased through transmission. Two that I'm going to mention that are somewhat unique to breast imaging are orientation. Something is either parallel, and it's parallel with the chest wall, or anti-parallel, like you've turned it where it's anti-parallel to the chest wall. Anti-parallel is bad. Parallel is a descriptor that's used for more benign things. And then whether or not something is circumscribed, like this mass lesion here where you could draw all the way around the edge and has a crisp border, versus this, which is not circumscribed, and non-circumscribed has its own group of descriptors: indistinct, angular, microlobulated, and spiculated. I encourage you can read it in my book, or you can Google it, look at the most recent BIRADS vocabulary set, and be familiar with all the different words. It's pretty straightforward, you just have to memorize it. Now, BIRADS also groups things into the standard reporting isn't just for vocabulary words, it's also for risk stratification, and it helps you decide what you're going to do. So, BIRADS 0 is something that means the exam is incomplete. If you were doing a screening set and the posterior nipple line didn't didn't add up on the CC, that would be an incomplete exam. That would be a BIRADS 0. If there was blur on the image that made it unreadable, that would be a BIRADS 0. If you saw a finding but you hadn't characterized it completely, which you never have if it's on a baseline, or you haven't done diagnostic workup, that would be a BIRADS 0, meaning that it needs additional workup. A BIRADS 1 would be a straight negative exam. A BIRADS 2 would be something that is totally benign, like a fat-containing lesion, or something that's previously been worked up like a cyst that's not changed over multiple priors. BIRADS 3 is complicated. We'll talk about that some in the next lecture and also in the following lecture. BIRADS 4 and 5 are you saying that this needs a biopsy. BIRADS 4 is you're saying it needs a biopsy because you're covering your ass. BIRADS 5 is it needs a biopsy because you're sure that it's cancer. And there are percentages that are thrown around. 95% or greater chance of cancer is a BIRADS 5. And the other thing that's important between BIRADS 4 and BIRADS 5 is that if you BIRADS 5 something and you biopsy it, and then the pathologist tells you it's benign, you have to recommend surgical excision and a surgical biopsy. If you BIRADS 4 something and the pathologist tells you it's benign, then that's acceptable. So that's a concordant versus discordant pathology result. And you have to actually follow up your biopsy results, unfortunately. Now, there's also BIRADS 6, which is path-proven. I didn't include that in there. So here's the basic structure of how this works in the United States. A patient who has no symptoms, that's just following regular annual screening recommendations, is going to show up and they're going to get a screening mammogram. And that screening mammogram is either going to be technically abnormal, like posterior nipple line's not good enough, or there's blur, or there's motion, or there's grid lines, or something that keeps you from reading it. It's going to be normal, or it's going to have a benign finding on it, like a fat-containing lesion, or it's going to be abnormal. So normal ones or technical callbacks get repeated. Well, technical callback will get repeated. The normal will return to screening in a year. An abnormal is going to get a BIRADS 0, and it is then going to enter the diagnostic call pool. And depending on who you talk to, the technical callback will enter the diagnostic call pool also, just because it's considered incomplete. This is sort of semantics. I don't think they would ask that. So once you've entered the diagnostic call pool, you're going to get additional imaging. You're going to get spot compressions or mags if you called calcs, and then you're going to get an ultrasound if it's a palpable finding or if you think that it's real. Calcifications are the only... Even calcifications oftentimes will still get an ultrasound if you think there's an underlying mass. So you're going to get additional imaging, and then that is either going to be... Well, back up. So that's one way to get into the diagnostic call pool, is to have an abnormal screener. The other way to get in the diagnostic call pool is to have a symptom. So this is distinct from this here. These people have no symptoms. They're just showing up because they were told by their family medicine doctor that they need to get a mammogram. The patient who has a palpable finding, nipple discharge, or the dreaded breast pain, which is always benign, will end up entering the diagnostic pool. So these are either going to be normal, where there's nothing, it doesn't, you don't find anything, any kind of finding, or it doesn't persist when you do spot compression, or you work it up and you find that it's a simple cyst, or it's a fat-containing lesion, And these people are going to go back into the screening pool. Or you're going to say that you found something and you're going to send them to the room of tears and tell them they need a biopsy. Or there's the special situation of BIRADS 3, which I'll talk about in other lectures. And this is pretty much how it works. This is probably the most important diagram that I can show you with regard to multiple choice tests, because breast, more than any other thing in radiology, is going to lend itself really well to the next step type of question. What do you do next? What do you do next? Because there's a big algorithm here, right? And they could start you out as a screener and then work you through a pathway. They could start you out as a diagnostic and work you out as a pathway, and they could ask you questions. Does this person go back into the screening pile? Does this person go for a biopsy? So understanding this is really important. And for people who have done mammography in the United States, it's easy, but if you haven't, it's often very foreign and challenging. So let's practice. Let's do one together. Now, the general idea on how the reports work is, first thing is whether or not it's technically sufficient. Second thing, like I said, is you have to describe the breast density. Is it fatty, kind of fatty, mostly fatty, or totally dense? Is there a finding? What breast is it in? Remember the clock face, measure it, location, and then the other, vocabulary word descriptors. And then you end up giving a BIRADS, and which is going to be a 0, 1, or 2 off of the screening. And then it's going to be a 1, 2, 3, 4, 5 off of the diagnostic. So here we go, 98-year-old. This is a standard 98-year-old unit screener. Yes, women in the United States will continue to get screening mammograms for basically ever. So there's a finding. So this posterior, this part right here, this is where most of the breast cancers, you tend to end up catching them. And back in here also, things don't belong back there. So there is a finding here, not necessarily seeing it on the CC. So this is a situation where we have our MLO only. But let's look at the old gold. So if they ask you what to do next from there, it would always be to look at the comparisons, just like if you're reading a chest x-ray. And you can see that this is a new finding. It's going to be described as an asymmetry because we only saw it in one view, or it wasn't in the other view. But it's suspicious, right, because we know that it's new. So we had a screener. We called it abnormal. We said there was a finding there, so now we're in the diagnostic pathway. So this was a BIRADS 0 because we said it needed additional information, and we're going to get a spot compression and a full lateral because we only saw it in the MLO. So here we go. We've got our diagnostic exam, and again we're seeing our mass here, which looks like on the true ML is probably this thing. So don't think that it's risen. It looks like if anything it stayed the same, or it probably dropped just a little bit. So lead sinks. So I'm expecting that it's going to be in the lateral breast, even though I'm not 100% sure that I'm seeing it on this CC view. I would probably describe this thing as high density, either high density or equal density. Remember that we're not comparing it to the fat, we're comparing it to this breast tissue here. So it's either high density or equal density. It looks like it's probably round, and that the margins are either obscured or spiculated. Here we go, and got our ultrasound, and this is what a breast cancer looks like on ultrasound. It's a shadowing mass, it's irregular, the margin is indistinct, anti-parallel. It's got all the bad things. It's bad. It's bad. That's a cancer. So we have to BIRADS 5 that based on the ultrasound appearance. Based on the mammographic appearance, it could have been a BIRADS 4, but once you see that it's got like every classic feature of a breast cancer on ultrasound, then you have to BR5 it. So you're going to recommend biopsy, and you're going to choose the modality that you saw it best in. In this case, we saw it best in ultrasound, so that's what we're going to use to biopsy it. So we had a screener, we called it abnormal, we called them back for additional views, they made them a diagnostic, we localized it, and we did an ultrasound, and then we BR5'd it, so we sent them to the room of tears, and then we said we were going to do it by ultrasound, this biopsy, and then based on the pathology that we would get back from that, because we BR5'd it, we would only accept a malignant result. So the pathologist would have to say it was cancer, and if they didn't, we would have to send them to surgery for a surgical excision. Now here's a highly testable point. Before the patient leaves on that ultrasound, so if you go in there and you see that on ultrasound, and then you're confronted with a what is the next step type of question, you will want to scan the remainder of the radian. Remember, that was like that triangle of breast tissue, or the quadrant of breast tissue, and you also want to look in the axilla to see if there are abnormal lymph nodes. So this is the end of the first part of the breast lecture series, and the second part will be a whirlwind tour of breast cancer.